So hi everyone. Welcome to the second webinar of the day. So we had a similar session earlier this morning around 12 p.m. UK time, and to morning, afternoon, and or evening to wherever you're at. So this is a combined national leads and hospital leads webinar that we're having, and this is the fourth one. And this aim of this webinar today is really to talk about where we've come to with a focus on data validation and talking about our one-year follow-up and really about the next steps and where we're headed to. So without further ado, this is the overall arching event program, and I'm going to pass you on to John to give us an update as to where we are and the next steps.
Yeah, hi. My name's John. I'm a fourth year medicine student at the University of Birmingham, and I'm on the steering committee of GECKO. You may have seen some emails, and quite a few when you were sort of in the early data collections and the registration period. So this is highlighting just where we are at the moment. I mean, I know you all probably know where we are at the moment, but we're actually sort of, we finished all the data collection periods. We're quite near the end. We've now locked the data, or we've passed the deadline, the 15th of January deadline for the data lock. And then we're going to go through the next steps, which includes validation, analysis, and the year follow-up as well, and whatever publications then come out of it. So if you could move the slide. So this is a little graph just to show a little statistic to show where we are and how much we've achieved. And I think more people are going to mention this tonight, in that we're all very amazed by how big GECKO has got, and the data is quite impressive, like the number of records we've managed to get from around the world. So we've got over 52,000 records. That's before the cleaning, I think, and so it's not the final number, but I don't think we expect it to be vastly different, and so that's really, really impressive. And we're in, over half the countries. We've done fantastically in terms of like spreading GECKO around, and you've all done amazingly. So this is again just another stat, just showing where the data has come from, particularly with like the data. If you look at this one on the left with the data collection period, we've actually only got very little data missing, which I think is quite impressive, as a roughly even spread among all the periods. But that last push to submit and upload all that data was really effective, and so well done everyone on that. Again, another little stat page, just showing a sort of leaderboard, if you will, of countries and also centers. So the centers is on the left and the countries on the right. So yeah, there's some really big numbers coming in from the centers, and also from the countries. You can see the order there, which is really cool. I think now I pass it on to Rinu, because that's my bit done. It was very short, but yeah, thanks.
So thank you for that, John. So I think for those joining, we've just given a good summary of where we're at. More than 50,000 patients. I'm now going to pass you on to Dr. Rinu Pius, who's going to talk to you about data validation, which is a really important next step for us all. And off to you, Rinu.
Thank you very much, Sibash and John. Hi, everyone. My name is Rinu. I'm a senior data manager working at Edinburgh University Centre for Medical Informatics. I will be running the validation part of the study. Together with other team members, we've already obviously started data cleaning and looking at data quality in general. And I can honestly say that I'm blown away by the quality of this data set. There's hardly any missing data. How have you achieved that? All of your hospital leads, national leads, it's already looking like very high quality, which actually makes validation even more important, because together with validation, we can push this into a really high impact journal. So I will, before I introduce the validation process, it is really important to note that once data is cleaned and checked by our team and it passes on to validation, you're in authorship. No one will be removed from the manuscript or the authorship based on validation results. This is, well, there are a few methodological reasons for this, which I'm not going to go into detail. However, it does mean that validators are under no pressure to say hide or any, you know, they can't be pressured by the original team to hide any mistakes, because the original team's authorship and contribution will not be affected. And I'll explain how that works in the manuscript and why we do that. But validation will not remove or exclude anyone. If you made it into validation, you've made it. So the validation part of a data collection study looks at two things separately. One is data accuracy and the other one is ascertainment. Accuracy is within each patient record, is the information accurate? So for example, if the record said the patient is 55 years old, are they actually 55 years old? Or if they had you know, surgery with that indication or a laparoscopic procedure, did they actually, or was it actually open? So accuracy is within the patient record. Ascertainment looks at how many patient records have been entered from the total number of patients, eligible patients who had surgery. So it's kind of looking, are any patients missing, rather than how accurate is the data of the patients we do have. And all high quality publications must report both of these two things. But as I said before, this information is not used to modify the original data set or change the data analysis. It will only be reported to give the reader and editor confidence in the data set. And I've said this, and I can't emphasize this highly enough, validation does not remove or even alter primary data. It just describes the accuracy and ascertainment. Sometimes people are tempted to say, well, why shouldn't we alter the original data? If we find the mistakes, let's fix them. But that's, we can't just fix the mistakes we find. We need to summarize the over quality. And also, if we then try to report 100% quality, 100% accuracy, and 100% ascertainment, no one's going to believe us anyway. That's not realistic. We all make mistakes. It's about counting up and trying to honestly, objectively assess how big of an impact those mistakes might make on the analysis. We're not trying to get rid of mistakes completely. And to give you an example, a recent, well, not so recent, a couple of years ago, we ran a very high quality study looking at cancer outcomes. It was called Global Search 3. It was published in The Lancet. And the data accuracy reported in that study was good and very good. So the kappa statistic between 0.6 and 99. And the case ascertainment was 96.4%. So you can see we didn't edit anything. We didn't try and get 100%. This is just the honest ascertainment that came up. So this is why we validate. And I will answer all of your questions at the end of this section. How do we validate? Each hospital lead registers one independent validator. The validator's information is added on the same registration form as you use to enter collaborators. The validator is ideally a surgeon or someone else in the hospital who has access to patient data, but also a good understanding of the data points and how surgical variables work. So this could be as a medical student, if the student is quite well versed in surgical kind of procedures and outcomes, and if they already have access, it's usually another doctor. This cannot be the hospital lead themselves because they already have access to the primary data set on REDCap, whereas the validator must not have access to the data entered by the collaborators. They must look up the data independently from hospital theatre logbooks or hospital paper, electronic records, any records you can find. It's a single person per hospital. However, they will not be validating all 8 periods. We will choose one of those 8 periods at random. Furthermore, the validator will only look at 6 variables per patient. So that makes the workload appropriate for one person. So they will not be validating the same set of variables that the original collaborating team entered, where obviously multiple team members work together. So this is a fair kind of fair workload for the validator. At the same time, it gives us enough of a picture on the accuracy as well as ascertainment. The validator email accounts will be emailed out at the beginning of February, and once they log into REDCap, they will find these 2 projects or 2 stages, stage 1 and stage 2, and these refer to the accuracy and ascertainment parts of validation. The validator can complete these 2 simultaneously. They don't need to submit one and wait for our approval. No, you can do both at the same time. Just make sure to finish it before the end of February. It's a leap year, so you get an extra day. And now I'm gonna go through a couple of quick slides on what the validation projects actually look on REDCap. So the validator logs in. There are 2 projects, validation stage 1, validation stage 2. The opening stage 1, you'll see the generic project landing page, and we will provide these slides as a guide. They'll be emailed out, they'll be linked on the website, so no need to, I don't know, take screenshots or anything. It's also been recorded. So if after clicking on the record status dashboard, the validator will see red dots. You see, I put 2 red dots here as an example of patient 1 and patient 2. There will be as many red dots as there were patients in that validation period. For most validators, this will be 10 or fewer. So, but you'll probably see about 10 patients or less. And entering the, say, the first patient record, at the top there, it will tell you your randomized period. So for just on this slide, it says 9th of October till the 22nd of October. So you'll only be looking at patients who had a cholecystectomy during that, between those dates. And the validator will be looking at these variables, which are listed here. So these are the 6 variables. They will come up later as well. These 5 variables are provided to the validator. So these are pre-filled. So these variables are there to aid identifying the patient. We don't have patient IDs or even dates of birth, because that's not appropriate to be shared in an international project for information governance laws across different countries. So the validator will need to identify the patient based on knowing the fact that they had a cholecystectomy between those 2 dates, between a 2-week period, and their age, sex, and the operative approach and the mode of anesthesia. Since most hospitals only perform 10 or so cholecystectomies in a 2-week period, it should be possible to use mainly the age, but also these other variables to identify these patients. And then there's a question, validator, did you identify this patient? If the validator sort of matches the patient, but thinks some of those variables were off or maybe mistaken, they can correct them. So, for example, maybe the operative approach had been entered as laparoscopic, but actually the validator can see that it was converted to open afterwards, and maybe wasn't, the original collaborator didn't record it properly. The validator can fix that. Maybe they think the age was off. They can try and fix that as well. But obviously be careful to make sure you've identified the right patient within that 2-week period. And then after the validator has identified the patient, they are presented with 6 further variables to enter, just 6. So I put 3 on this slide. There are further 3 down. And so the validator will enter what the urgency of the operation was, and also whether the patient had complications and a couple of other things. And we will then compare these values with the original data set. We will not modify the original data set. We'll just come up with the a kappa statistic for agreement based on these values. After the validator completes a single patient, they should set the form complete. Setting a form complete makes it turn green on the dashboard, and the validator must go through every single patient, fill in all the variables, and then all of the patient points will turn green. So you start off with red points, you want to finish with green points. Now, that was stage 1, accuracy. Stage 2 is case ascertainment, aka missing patients. The validator goes back to the REDCap login screen or their projects and clicks on stage 2. Stage 2, they expect to see a single line, a single record with 2 points. So the first point, and I'll show you what those 2 points are, but you will only ever see a single line with 2 points. When clicking on the first point asks exactly 3 questions. One is how to identify patients in your hospital. Second one is how to follow up patients in your hospital. And the third one is the most important one. Do you think there are any patients missing from the validation data set? So this is referring to the same dates, and the dates are given here at the top again. See periods, 6th, 9th of October to the 22nd of October. If in stage 1 you were presented with 10 patients, but when reviewing hospital logbooks, you could see that 12 patients had a cholecystectomy, and they fulfill the remaining eligibility criteria. For example, they are adults. Then the validator should enter yes, number 2, and then save and go to next form. 2 patients are missing. And then what happens on the next form? The validator will be asked to enter 6 basic variables about that patient. They will not be asked to re-enter a whole patient record. That's not necessary. We just need some basic, mostly demographic information to see whether there are any patterns in these missing patients. And then we can report on that in the paper. Again, none of this will affect the original data set. None of this will penalize the original collaborators in any way. This is only used for academic purposes, for data analysis and publication in the manuscript. And validators will also get the same kind of authorship on all our publications as original collaborators do. Now, this is the tricky bit, but don't worry, these instructions are also embedded as screenshots in the REDCap project, plus we'll share them with you. So you've entered 1 missing patient, but you actually had 2 missing patients. So you need to create a new dot for them, a new kind of form for them on REDCap. So you click on save and add new instance. Or alternatively, if you've closed the record and gone back to the record dashboard and you're like, oh, where's that button? Then there's this plus button next to those green dots. And you click on that plus button and add as many missing patients, 6 variables each, as you identified. And then after entering those variables for the missing patients, going back to the record dashboard, if you click on these, this pile of points, it will list missing patients data. You'll see that in this example, we have entered 2 patient records. They're green because we've completed them. And you should see how many, you intend to enter or how many you identified. So finally, to summarize, we have stage 1 and stage 2, both on REDCap. Stage 1 has a point for each patient that's already in the database. Stage 2 will have a single line asking if any patients were missed. And if so, you should be populating and creating more of those dots to enter six basic variables for each patient. Oh, sorry, I'm trying to go back to, yeah. So questions. Oh, there are 26 questions in the chat. Oh dear, oh dear, oh dear. I'm just gonna start from the bottom. Yeah, Natalie's already replied if the validator was initially a collaborator. The validation process starts in the beginning of February. So the first week of February, accounts will be mailed out, and the deadline is the 29th of February. As I said, the validator only needs to enter 6 data points. So a month to do 6 data points per patient should be enough. Sivesh, where will this recording be shared?
It will be shared soon after this, probably on Monday.
I think the team have replied to questions in the chat, but if anyone has any questions about validation that they haven't put in the chat bot, could you raise your hands and then I'll ask you to unmute yourself and see if though I always lose the raise your hand option. I'm gonna raise my, yeah, found it. Nice, lower hand. Don't worry about it. We will have lots more time for questions at the end of the talk, including the panel members can share their experiences. So if you think of a question 15 minutes from now, you can still ask it. I'll be here for the full hour. And thanks very much again, everyone. And the data is looking very high quality. It's a great study, and it's gonna be a great analysis and useful useful analysis for all the future improvements that the NITR unit and LeapSay will do. Ahmad, hi, long time no see.
Hello, how are you?
I'm very good. How are you?
Nice to see you again.
Yeah. What's your question?
So it's a wonderful presentation and a wonderful study. I must appreciate the whole team and Sivesh, and Professor even now. But everyone has done a great, a tremendous job. My question is, would you be sharing this? I may have missed it in the start. You'll be sharing a separate account for the validators, right?
Yes, correct.
And it would be shared somewhere in the first week of February.
Yes.
So should I share this presentation now with the validator, or should I wait for the e-logs to be the logins to be shared first, and then we can give them this presentation, because there would be many. Every hospital has one.
Very good question. You can share this presentation with them immediately, and what more importantly, the validator needs to read the protocol, especially for the inclusion criteria, because the validator can't say how many patients should have been included if they don't know what the inclusion criteria was, right? So the validator needs to read the protocol and look at this presentation. Having just said that, if they look at the REDCap guide right now, in 2 weeks' time, they will have forgotten. I would have. I think they should
That's
start with
absolutely correct.
reading the protocol, but obviously,
The
yeah.
protocol.
Yeah.
And another question, right? So we do have the list of hospital leads, but we do not have the list of validators for each hospital. Now, should we be again approaching the hospital leads, or do we have a database that we can directly contact the validators for this?
No, only the hospital leads will know who the validators are. Yeah.
Okay, so we'll be again talking about the hospital leads that it is coming up. So the
Yeah.
presentation first has to be shared with the hospital leads, and they would be able to share it with their validators.
Yeah, but the hospital leads are on this call. So this is a joint national leads and hospital leads call. So this recording and everything will be shared with the hospital leads, but it's great to have national leads on here. So if hospital leads have any questions, what slides, what accounts, then you can remind them.
Thank you so much. And another question from with Savesh. I mean, Savesh, do we have any opportunity of entering data? Because some of the centers have asked me that they still have a couple of maybe more forms that they have in the written form. They have not included in them.
Yeah, so I think we've had multiple rounds of conversation with Renew and Ewan about this, and I think we made a decision to sort of extend it by a week. But I think
That would be wonderful. That
yes,
would be, that means that is 22nd, right? For
yeah,
some centers.
yeah. So on Monday we will lock the database completely to progress with data validation.
Wonderful.
So that's
Wonderful. That would be great. That would be great. Thank you.
Thank you. Thanks, Ahmed. Thank you so much, Renew. Was there any other questions for Renew whilst we're on the topic of validation, data validation? I see there's quite a lot of questions on the chat. I guess one question, Renew, that I think this is a common theme is who should be data validators, and some hospital leads get mistaken that they can be validating it. Just for everyone on the call, what are your thoughts on that?
So ideally, this is a doctor or surgeon working at the hospital. And the reason I say a doctor is they need two things. They need access to either the theatre logbook or patient records. So they need to have access to patient data. But second, they need to understand the meaning of surgical variables. They need to understand what the different aspects of complications are. This could be a medical student if they are well versed in surgical data and they have access. Some, for example, often final year medical students may already have access to patient records, and they may be doing clinical shifts. So it's fine for it to be a medical student as long as they have access, but normally a doctor. Or it could even be a clinical researcher, again, if they understand the underlying data and processes. Thank you. The question is, how long will you allow for validation? 1 month, so end of February, 29th of February, you get an extra day for a leap year, is the validation deadline.
We've got one question as well about if someone can cover more than one facility. I presume this is okay if they've got access to patient data at both facilities. Check.
Yes, if someone is willing to work extra hard. So that is, you have to email us separately, because on REDCap you can only access one hospital at a time. That is a strict limitation by REDCap. So that means that you have to coordinate with us, the managing team, to say, I finished this one hospital, could I be reassigned to the next one? You can't simultaneously validate two hospitals. That's a technical limitation. So ideally, we would have separate validators for separate hospitals, because then they can do it simultaneously. But if one person is validating two hospitals, we're very grateful, and you'll have to email us to facilitate that.
Renu, can I ask a question? I can't find the raise your hand. It's just, will the validator not be provided with the GECKO ID in order to identify the patients?
The GECKO ID is a random number made up by REDCap, so it doesn't actually relate to your hospital patient records.
Oh, yes, but if we had the GECKO ID for the validator, then we have kept a record of which, what is the hospital ID along with that GECKO ID to be able to easily identify the patient.
Yes, they will be provided with the GECKO ID on REDCap.
Okay, thank you.
Thank you.
I can't see there's any other questions at the moment, but I'm sure there'll be a lot more questions as we come up to the Q&A. So thank you very much, Reenu. So everyone just joining, we've just finished data validation, and we're going to move on to the 1-year follow-up, which is another important part of the study. So Natalie, over to you.
Thanks, Savash. So I'm Natalie. I'm a PhD fellow at the University of Birmingham. I'm just going to go through quickly about our 1-year follow-up, seeing as that we've been so successful in recruiting for the GECKO study. So hopefully looking at longer term results of the patients we've collected for GECKO. So what we want to do is to be able to perform a follow-up of all of our patients that we have collected in the GECKO study at 1 year. And our main focus in this part of the study is looking at bile duct injury and also those that develop gallbladder cancer. The reason why we're doing this is that it will hopefully help us understand more long-term management of patients that end up with a bile duct injury as assessed by guidelines, and also this longer time period will also help us identify those that develop gallbladder cancer and how these are managed. Usually we're not able to detect this within the first 30 days or identify this in the first 30 days or so. Both of these will be collected on the pro forma that we have already on REDCap, and also we want those that have filled up the pro forma for the bile duct injuries and gallbladder cancer to also follow up this in the section that is the 1-year follow-up part of the pro forma as well. So there's a few sections that need filling up if possible for these patients. And the way that we're trying to maximise the follow-up of these patients is that hopefully everyone has kept a list of the patient ID and their corresponding REDCap so that we can identify these patients and follow them up so that we can input it. As this is a follow-up study, hopefully we can ensure that your audit office and the local governing bodies are aware of this, and hopefully no new ethics are required to be able to input this type of data. For those that are collecting this data at 1 year, obviously we know that people move on to different hospitals, or and that you'll have a new intake of people inside your team. So we're able to offer new registration for members that want to join and collect the 1 year follow-up data, and we can organise this and email these new IDs out for these individuals in the following few months.
Thank you so much, Natalie, for that whistle-stop tour about 1-year follow-up. So I guess I can't see any questions at the moment, but just a question for me and for everyone else watching. Can people start filling up some of the data around histology and follow-up information in real time whilst the other forms are locked, or should they just start at 1 year from the time they've had the operation? Natalie?
Sorry, I missed that. What did you say?
So can people follow up their data real time and input it real time into REDCap, or should they come back to it at a year?
You can try and do as much as you can now, but you can also do it at 1 year, whatever's easiest.
Thank you so much, Natalie. So I think we've come to a stage where we've collected a whole lot of data and we're at the stage of cleaning it up and performing validation. So I'd like to invite Professor Ewan Harrison to give us an update as to what is the long-term vision of this collaborative and where we should be taking it towards moving forward over the next few months to a year.
Thank you, Savash, and it's lovely to see everybody. My name's Ewan Harrison. I'm a professor of surgery and data science in Edinburgh University and one of the global surge leads. And as others have said in this call, what an exciting time and what an amazing amount of work has been done by this group and the collaborators that you're working with within your countries. The data is phenomenal, and it represents the largest study in cholecystectomy which has been done worldwide, I think, as we all probably know. Data analysis has commenced, and data analysis will continue while the validation project is ongoing, so that won't slow us down. When publishing these studies, the aim clearly is to have a first initial study in a very high impact journal. And publishing in a high impact journal is all about the message of the paper. The subject of the study, the methods of the study, they really don't matter so much if there is a really striking message. So we are exploring this at the moment, and it is likely that the first paper and the first message won't be about the day-to-day management around cholecystectomy, but will be a broader, generalizable paper on a global level, looking at, for instance, minimally invasive surgery infrastructure worldwide. And we'd be aiming for that to be published in a Lancet stable journal, as they call them. At the same time, we will be putting together a manuscript by surgeons for surgeons, if you like, on the management specifically around cholecystectomy, aiming for that to be published in a high impact surgical journal. So that's the plan for the first 2 manuscripts. There will be, I hope, many manuscripts to follow, and in particular, we'll be looking at the 1-year data to publish the bile duct injury and cancer outcomes as two separate studies. Those of you who have ideas around papers, please share them. Please take part in the process of writing the papers as well. From the point of view of where we go after all of the analysis and outputs have been generated from the study itself, we really like to think about these observational studies as being stepping stones to an interventional study. So an interventional study or a trial would be a phenomenal next step for this collaborative. Much harder to run, but the conclusions from it are much more robust in terms of causality, if you like. So there's lots of ideas percolating at the moment, and we're thinking particularly around a similar study to the EAGLE study that was done. The EAGLE study used an educational intervention to try and improve outcomes after right hemicolectomy. So a similar type of study in cholecystectomy could be around a checklist or timeout at the time of critical view of safety, for instance. That could be implemented as a cluster design, so at the level of the hospital, and we could see whether we can reduce complications, reduce bile duct injury, using an educational intervention, particularly associated or particularly aimed around cholecystectomy. So those are the ideas, and we're really interested in your ideas as well, and in how you think we can be taking forward this fantastic collaborative. So thank you very much again.
Thank you, Ewan. I guess one question whilst waiting for others to come through is, how might they be able to reach out with ideas or potential collaborations from nationally?
Yeah, so there's various different roles that people can take. So everybody who has been a national lead or a hospital lead or a data collector or a data validator will be included as an author, as a PubMed citable collaborator on the paper. There may be those that wish to get more involved in the analysis. There may be of a statistical mind and would like to learn more in that area. If that is the case, then please get in contact via the standard email, and let us know exactly what you would bring and exactly what you feel that you would want to get out of it. There could be opportunities. We're obviously a relatively kind of small core team, but there could be opportunities for doing country level analyses as well. So potentially you're in a country that has collected a significant amount of data, or a region that's collected a significant amount of data, and wish to ask a specific question relevant or of interest in your particular area. If that's the case, then we could let you know exactly how to go about setting up that sort of study. Renu may wish to say more, but it involves getting in contact with the various different hospitals who have contributed data in your country or region and ensuring everyone is on board with the idea.
Thank you so much, Ewan. So I think at this stage, we've got a few national leads who might want to come in to comment around the data validation or the one-year follow-up or all the exciting avenues that Ewan has kindly laid out for the collaborative as a whole. So I can see Richard Crawford, who's one of the national leads in South Africa, is online. Richard, would you like to come in and comment on your views about issues around validation that you might have encountered, or comments on some of Ewan's points around the future of the collaborative? Richard, I'm not sure if you're available.
Hi, Sudesh. Thanks so much, man. Fantastic presentation, guys, and really well done so far on the cohort and the study. I know for South Africa perspective, our biggest problem is we don't have an electronic database. And so to follow up the patients at 1 year, unless they've recently presented in the last 2 months where we have their paper-based access to their records, it's going to be extremely difficult for us to try and follow up with them. So all of our histology slides I know have all been logged, so that at least we got. But in terms of bowel duct injuries, and that's it's going to be difficult. I think the direction of the paper that you intended is absolutely fantastic. I'll definitely give it some thought and think to some HPB guys to see from a local South African perspective, but nothing further to add at the moment.
Thank you so much, Richard. I think it's a really important point. I think I probably want to ask Renu or Ewan to comment on in terms of 1 year follow-up. I think some people are worried about the loss of follow-up as a result of it's not routine for a lot of patients to be followed up if they don't really have bowel duct injuries or gallbladder cancers. What are your thoughts, Ewan or Renu, on that matter for everyone on the call?
Do you want me to go first, Renu? Yeah, it's difficult. And one of the success of global surge style projects is the snapshot nature of them, you know, only looking at 30-day outcomes, which is the vast majority of collaborative study work, makes it much easier to collect data and to have high accuracy, but also high data completion rates. However, looking at longer term outcomes is much more valuable. And particularly when you start looking at cancer, there's not that much that can be said looking at 30-day outcomes from gallbladder cancer. So as an HPB surgeon myself, and we have been working closely with the IHPBA, the International Hepatobiliary and Pancreatic Association, they were very keen, as we were, to try and get longer term outcomes, which is why bile duct injury and cancer we're looking at for a year. As Richard rightly says, for those working in health systems that don't have electronic patient records, or it's harder to find out what's been happening to the patient over at a later date, that can be really, really challenging. One thing that a number of countries has done in the past is phone up patients. And, you know, for instance, the Ghana team phoned up all of their patients for all of the global search studies because they simply didn't have the means to check outcomes otherwise. So I would encourage everybody to be creative and really to think deeply about whether it might be possible by hook or by crook, by phoning a family doctor, or by phoning the patient themselves to find out what has happened over the course of the year. There's some hands up, so take Ahmed Qureshi first. Lovely to see you.
Thank you so much. It's really nice to see you as well. Good points. For the cancer patients, 1 year follow-up would be a long time, because what we see that the patient would develop metastasis earlier than the year, and many of them they do not unfortunately survive for that one year part if it comes out to be malignant. As Savesh said, we are collecting the data, and we get the biopsy, the histopathology report within the first month. So we would be collecting the information, right, while we are doing it. Already we have done for several months now. And for the injury part, yes, for the injury part, what we are planning to do is we are making asking them, giving them a number that would be with us, and they can contact us through a WhatsApp group on that. So I think we would be able to follow them over the year, because they would be around, they would be asking questions if they have a problem. So I think, yes, we're calling them or asking them to contact us through the WhatsApp is one of the interventions that probably would help us in following up after a year also.
Yeah, thank you, Ahmed. They're really important points. And I mean, as you rightly say, the outcomes from gallbladder malignancy are poor. We hope in this study, I guess, to be capturing quite a lot of the T1As, T1Bs, even T2As, 2TB, T2Bs. So those that have been incidentally found to have gallbladder cancer at the time of cholecystectomy for another indication. And in those groups, in the stage 1 groups, we'd be expecting to see 5-year outcomes of, potentially up in the 70–80%, because the cancer has been fully excised at the time of cholecystectomy. Be that whether a liver bed resection and lymphadenectomy has been subsequently done. So the points are well made. And like I say, if we are able to capture the data at 1 year, then this would represent the largest study of gallbladder cancer that had been done worldwide. Arda Isik, can you introduce yourself as well and say what country
thank you
you're
very
from?
much. I am Arda Işık from Istanbul Medeniyet University, Istanbul, Turkey. First of all, thank you very much for this valuable meeting, Ivan and Sivesh. Thank you very much. And I am glad to be here. I have 3 questions. 1 year follow-up will be difficult in some hospitals in Istanbul, because the surgeons who are responsible for 1 year follow-up data may move to another hospitals, and it will be difficult to validate data then. It is more common the surgeons change hospitals in 1 year time. And what can we do in this status? And the second question, what will we do for patients who we missed follow-up because of the patients or because of due to us? And the last question, 1 year follow-up for gallbladder cancer is, I think, a long period, because the survival for gallbladder cancer is not too long, as well as I know. Maybe check it on 6 months. Thank you.
Thank you, Arda. Really good questions. I was looking at the data today. I think Turkey has 1,974 patients recruited. So it's clearly going to be difficult to phone up. I mean, I'm sitting here saying, oh, just phone up the patients. Phoning up 2,000 patients is a huge logistical problem, even if the kind of ethical and the patients have a phone and everything. I mean, we do get that. So, I mean, what can I say? I would hope that we could get to a point where we think if a patient has had gallbladder cancer, then they will have come to light as part of this study. So it may be that the majority of patients we don't have good quality follow-up data on, but that those that we don't, we can presume that they have had neither a bile duct injury nor a cancer, because we haven't heard about it. Now, clearly there'll be patients in the community who, as you rightly say, develop gallbladder cancer and go on to an immediate palliative care pathway or die, and maybe don't come to light in the hospital in which they had their gallbladder. That's the nature of it, I guess. But we would be hoping that those that had these poor outcomes would have come to light. So if there's anything that you can think of that that could be used to highlight these patients, maybe talking to emergency department colleagues. If you see somebody coming in who has had a cholecystectomy, then, you know, let us know, or anything that you can think of that might work in Istanbul and other centres in Turkey would be greatly appreciated. Mohammed El Hadi, good to see you.
Hi, Professor Harrison. Hi, Suresh. I don't know. How are you? I'm Mohammed El Hadi from Libya. Nice to see you again. Do you hear me?
Very well.
Yeah, fantastic. Regarding the follow-up on 1 year, I would suggest if you could let the collaborator, at least based on my experience and previous studies, we usually get the patient's number and their relatives, like spouse or sibling or their son or maybe daughter, trying to contact them. And for the bile duct injury, I assume, at least based on our experience, it would be difficult to do it at 1 year. Usually, I would suggest that the collaborator try to contact them maybe a little bit sooner. The problem is, as also Arda said, sometimes the patients may transfer to another providers. We lose follow-up. Even we try sometimes to call them. Sometimes we get the patient, sometimes we get their relatives on phone to get this information, but sometimes it would be very difficult indeed. So I think we need maybe to try to encourage, as you previously mentioned it, to try to contact these patients a little bit sooner. Of course, this can get to be completed at 1 year, but maybe I think that would be the only way to do those, because I know a lot of patients will lose a follow-up and they will not return to the same hospital. So it's difficult to depend on the hospital record, for example, or the surgeon itself. Thank you.
I mean, you're absolutely right, Mohammed, that there's this balance between allowing a sufficient amount of time to have passed in order to be able to definitively say we have the final outcome for this patient, but not to wait so long, like a year, when it might be hard to get in contact with the patient, or they may have, I don't know, they may have forgotten, etc. So the follow-up REDCap sheets, the follow-up REDCap forms will be open for the entire year of data collection. So if you follow up the patient at, you know, from a bile duct injury point of view at, say, 2 months, then that data can be completed there. It'd be very unusual not to know about a bile duct injury within, what, a handful of weeks after surgery, unless we're talking about some long-term stricture, which probably wouldn't be considered a bile duct injury and we could forget about.
Exactly.
I mean,
Yeah,
similar to Arda in Turkey, there are 731 patients in Libya.
Yeah.
The North African countries have done an amazing job across Egypt, Algeria, Libya, Morocco. You may want to think about a regional analysis in North Africa. That might be quite interesting to do. But I think your ideas around how we can improve follow-up are great, and I hope others listen to that advice and are able to act on it in their own country as well. So thank you.
Yeah, thank you.
Thank you so much, Ewan and Arda and Mohammed, for that really exciting discussion. I think we've got also a couple of national leads from Canada and from India. So Janet Parvez, I'm not sure if you can hear us or if it's a suitable time to talk. If you want to just sort of share your experiences or any comments from the call so far that might be of use to everyone here today. Parvez, Janet?
Hi there, Savesh. I'm hoping you can hear me. Is okay? Great. Hi, everybody. It's Janet Martin here from Canada. My city is London, and it's London, Ontario, Canada. And I'm from anesthesia, perioperative medicine. Just a couple of comments. First, I just want to, I know others have said this, but this is an amazing feat to have a study this large and just to have so many countries involved. I'm so encouraged by that because as you and as Professor Harrison has identified, having a publication that evaluates or compares surgical infrastructure worldwide itself would just be so invaluable, let alone the clinical outcomes that we'll be able to report as never before in a study this large. A couple of thoughts on follow up to 1 year. So in Canada, we were involved, a few of our centers, in the COVID surge head and neck sub-study. And in that time, we did a 1 year and a 2 year follow-up. And I think the experience that we had there, and it might be helpful for some centers, was that it was really helpful for us to keep in contact as national leads with our hospital leads that were participating in the follow-up, because sometimes you get some attrition in your hospital leads in that they might be moving on to other places, and then just to get the legacy of handing over the information to somebody else to have a new contact. So that's number one. And the other one that some hospitals were less familiar with was just the record keeping that was required in order to ensure that 1 year follow-up was possible. But again, congratulations, everyone. This is so exciting, and I'm glad that Canada was able to participate. And in terms of national level studies or regional level studies, I also would really encourage, I guess, countries that have, or regions that have, say, more than 300 to 500 patients. I think that would be really valuable to have additional publications, because that also gives you a chance to give your perspective on additional perspective on the local context. And that's also really meaningful, especially given that global surgery is, I think, rising in interest, and also of greater and greater attention now at the World Health Organization. So whatever you publish in that regard would definitely be of interest, I think, to the global surgery community as well. And I think I'll stop there, but again, congrats, everyone.
Thank you so much, Janet, for those comments. Renu or Ewan, was there anything that you'd like to come back on in regards to? So I think some of the takeaways that I've certainly learned is just about the 1 year follow-up for hospital leads and national leads over the call today, and also for the call earlier just now. So I think it's been such a great productive conversations that we've all had around where we've come up to and all the work that has gone in over the last few months in terms of setting up and the day-to-day delivery. I think all of us have completely learned a lot. I've just seen Parvez, you've got your hand up. Would you like to come in?
Hi, good evening, everyone. I'm really sorry. I'm in transit right now at Delhi railway station. It's pretty noisy. And what I will just say, congratulations to everybody to get this huge number. For Indians, to get a score on board for cricket is what is the way to win ahead. And, this was something we really look forward to. I'm very happy with all the centers in India who participated, and it was very encouraging for us how you all have been patient. Yes, definitely, we're looking forward to the 1 year follow-up period. That will be some form of, there will be some barriers to that, because the patient load which we have been able to represent comes from the very rural area. So let's see. We've tried our talent scheme over here, where we've tried to retain the mobile numbers, and as many patients who can follow up, we'll see. Thank you.
Thanks so much, Parvez. So as I think for everyone on the call, and national leads and hospital leads, I think your follow-up methods is probably going to be context specific. And I think those are sort of the themes that have come up. And we as a steering team will sort of think back as to what strategies we can help with from our end to support everyone here today and not here today. So I think it's 6 to 5 here in the UK, and I'm sure for some of you it might be quite late in the evening. So I think we'll try and draw a line and draw close. And before then, Ewan, Renu, any final words before we sign off?
Can
today?
I further add that I work on a lot of different projects and I review a lot of different project proposals, and surgical projects never report follow-up longer than 30 days. And I'm sure one of the reasons is practice. Surgeons lose their patients to follow-up. However, if you could do, like Ewan said, whatever you can do to get as much follow-up data in here, this will be a truly unique study and will be remembered by all the other surgical studies in the future as the surgical study that achieved longer than 30-day follow-up. Thank you.
Thanks, Renu. I think it's certainly resounding for everyone to bear in mind that that's going to be a massive achievement for all of us today. Ewan, any final remarks?
Are we going to have a prize for the hospital that recruited the most patients?
Oh, I haven't thought about that yet, but I think it's something for at a hospital level, but also at a country level, and also maybe for the global surgery meeting at later in the year. Katie has some ideas. But yeah, no, thanks everyone. I think it's been great, and really look forward to sort of developing this family, this collaborative, as we move forward in the coming months to years. So thank you everyone. Have a good evening and start today or yeah, weekend ahead. Thank you very much.
Bye.